Dear colleagues, good day to all. My name is Martin Grobusch. I'm professor of tropical medicine, travel medicine at the University of Amsterdam, and I'm also wearing a couple of other hats, mainly in research institution across Africa. My topic today is to discuss with you briefly how to identify the source of sepsis. Now, I'm focusing on sepsis in low and middle income countries, and with reference to this excellent reference source, I would like to start with reminding us that if we talk care of sepsis, there are different standards, of course. So we know that there's a lot of difference in possibilities and capacities, whether we are discussing sepsis care in high-income countries or in low or middle-income countries. And this table about what should be available or what is usually available and what's not just serves as a reminder of this fact, actually. Now, focusing on the recognition of sepsis in resource-limited settings, and again referring to this excellent source of reference, I would personally say that we have four topics or four issues to consider. Actually, recognizing sepsis requires mainly background knowledge, epidemiological context, alertness to the problem, and the clever use of certain scoring systems. So the point I want to make here is that even without sophisticated tools, the essence and the core of good sepsis care is to recognize it early, actually. And that leads us, of course, to the problem of identifying the source of sepsis, actually. Again, meticulous history-taking, physical examination, and then imaging as far as available and as far as necessary in case there is an undetected source of a bacterial or other infection which leads to sepsis or a sepsis-like picture is really essential in making sure that we try the optimal in sepsis care. And that applies to all settings, from low and middle income country settings to high care settings in affluent countries, actually. Then, of course, the next step would be, as far as possible, the direct, or if not possible, otherwise the indirect identification of the causative pathogen, or at least a very well-educated guess to facilitate optimal therapy, actually. And of course, the extreme form of sepsis would be septic shock. And again, we need the same set of skills which alerts us early in the disease to its existence. So it's a thorough background knowledge of that what we are dealing with might be septic shock, actually, an epidemiological context, alertness to the problem, and again, the good application of one of the available scoring systems. Now, this overview broad world map is again taken from this formidable overview book by Achim Dondorp and colleagues, and it just reminds us in a very placative way that sepsis is rather a sepsis syndrome, that sepsis is far more than a bacterial infection. There can be sepsis-like disease pictures, such as malaria as one example, or dengue. And as I'm just illustrating here in a recent paper coming from my group, actually, it also means we really have, if we are dealing with a sepsis-like picture, we have to have a very good idea of what pathogen we might be dealing with. And very important diseases such as severe malaria or severe dengue can also come in the disguise of a bacterial infection. And they might, as I illustrate here with the example of fluid therapy, they might require very, very different approaches. This is just an example without me going into details that apart from the common bread and butter pathogens beyond malaria, we also need to think about diseases which we usually do not associate easily with sepsis. This is a recent paper just published by my group where we systematically look into tuberculosis as a sepsis-like disease, in this case, in HIV-negative patients. So we need to think broadly, irrespective of the fact whether we are able to identify an organism down to species level and maybe even assess its resistance pattern to the therapy we want to choose. Yeah. It all starts, however, again, no matter in what setting we operate, with knowledge and attitude, actually. So, as I said already, even in a resource-poor setting, and maybe particularly there, awareness, alertness, and basic knowledge about what in which disguises and with which features sepsis might present before it progresses to sepsis shock pattern is really essential. And here I'm just referring to one paper, and this has been done by our group together with those of Jamie Ryland and Shevin Jacob across Southern Africa, including Malawi and Gabon and Central Africa. We looked in detail into the level of knowledge between the various levels of healthcare workers. And I think, again, I just want to use that to reiterate that thorough knowledge assessment, excellent retrainings actually are required to allow people going the first mile, which is the most important in sepsis recognition and treatment, namely the very, very early identification of patients at risk or patients who are already trundling down a path towards sepsis and maybe later septic shock, actually. Now, what tool, once we have realized that a patient might be at risk, actually, what tool or which tools do we have to identify sepsis early or to alert us to a risk of a patient developing sepsis? There is a whole range of scoring systems. Some of them require a certain level of sophistication in terms of tools to be applied. Some really simply rely on our clinical skills, on basic vital function assessment, and in an attempt to compare quite a number of those scores with each other with regard to their functionality in low and middle income countries, we came to the conclusion in a recent systematic review and meta-analysis that individual score performances range from poor to acceptable in various settings, and that future studies should combine maybe elements of the various different scores. And it really shows us not a single size fits all, actually, and what we might need is scoring systems which are really adapted to and optimized towards the individual situation and individual settings. This is just, and I'll furnish you with the PDF of this talk so you can delve a little bit deeper, look up papers of specific interest. But what we did here is simply that we tried in a meta-analysis to pitch the various scoring systems against each other in the broad categories of low and middle income countries, not being able to take into account really individual levels of care, individual availability of certain diagnostic tools in particular settings. And we pushed that a little bit further in an original contribution here, where in our middle income setting in the middle of the Central African rainforest area at the old Albert Schweitzer Hospital, we pitched different scores against each other and figured out that when looking retrospectively at the different scores, as one example for what I said already, an amalgamation of certain scores, and in our case, the qSOFA and the UVA score, might be best doing justice to individual care situation. This is just a reminder of the various score systems which are considered as well established. As you see, the quick SOFA score, quick sequential organ failure assessment, is only making use of very, very basic tools. Actually, it can be done rapidly and is widely propagated in low and middle income countries. Then we have more sophisticated score, the MOD score, for example, a systemic inflammatory response syndrome score, SIRS, and the UVA score, the universal vital assessment. And as you can see, if you delve deeper, most scores rely on basic and essential clinical and nursing skills to make the basic and rapid assessment, but some of the more sophisticated scores, they require some level of laboratory assessment, such as a full blood count, or in some cases, which might be difficult, even when rapid testing is available, they factor in HIV serostatus and so on. And everybody will have to see in his or her individual setting which score is best. But I do believe that there should be no accident and emergency department where it is not possible, or where the usage of scores is not encouraged, actually, in order to identify patients at risk early, actually. Yes, and here, just for those interested, you can look it up in your PDF or refer to the original source, is to show the complexity that depending on where a score is used, depending on the level of training, depending also on need. In a very low HIV seroprevalence area, it might not be necessary to know about the HIV risk or prevalence at the beginning of an assessment, etc. In others, it might be essential. Actually, this is just a slide summary, and I'll talk you through this quickly, actually, about the state of the art of identifying a pathogen, actually, responsible for what we consider as a sepsis-like picture. And because it is so important that sepsis-like picture is not only caused by bacterial pathogens. Actually, every unit where patients at risk for severe disease are looked at, particularly in tropical areas, of course, we need to have a broad differential diagnosis, which does not require the backbone technique, which I think in a way is still essential to provide optimal care for sepsis patients wherever it is possible, and that is, of course, blood culturing. But blood cultures, which might be only available in a single reference hospital somewhere in a country, or maybe even not there, it is important that in tropical settings, of course, with the tools we have, rapid testing, microscopy, antigen testing, diseases such as dengue and malaria, which we don't diagnose by blood culture, are of course considered first and recognized early. But wherever possible, it is fantastic if we do have access to blood cultures. Actually, we can manage sepsis, of course, without, but wherever possible, proper use of blood cultures, either for every patient, wherever this luxury is, a relative luxury is affordable and feasible technically, or in higher level of care units in affluent countries. We are now moving not away from it, but going a step further, applying maybe MALDI-TOF wherever possible for quick results of identifying and characterizing a pathogen, actually. Yeah. Now, the first step, as I said, in any case, is the alertness toward the possibility that somebody is suffering from or developing sepsis, actually. The second step, of course, is to make clever decisions on supporting the patient irrespective of the pathogen. The third step, of course, then is identifying the pathogen. And as I said, many of those are bread and butter organisms in an area of malaria, high malaria endemicity. Of course, a sepsis-like picture could be due to severe malaria. So one would diagnose malaria in an area where dengue is the eminent diagnosis. Actually, in the first place, we have to take into account that dengue fever might also cause a sepsis-like picture, etc., etc. But whatever we do to assess sepsis, to address the diagnostic problem, there is across all settings, actually, irrespective of where we apply those tools, there is maybe a group of 10, 12% of critically ill patients where we have to deal with sepsis of unknown origin, where it's very difficult to identify the pathogen and also maybe a focus, a source of the infection within a person. And this work here, to which I refer to a study in more detail if interested in the PDF or in the original publication, shows how difficult it is to come to a conclusion that a pathogen cannot be identified, depending on the level of care which is available. The definition of this might differ. And I think one thing about sepsis of unknown origin, which is important, is that at least we know we are dealing with a sepsis-like picture, and we might be able to help the patient even if we are unable to identify the source. But of course, source identification is essential, and in order to do so, very often imaging techniques are helpful to identify a source of infection in critical body compartments, actually. Of course, we might wish to escalate the use of imaging in resource-rich settings to computed tomography or MRT use, or even other techniques. General X-ray might be helpful and is probably available, at least in most secondary level of care institutions, also in the tropics and higher up, of course. But what is increasingly important, actually, is the application of point-of-care ultrasound, which has been developed over the past decades into a formidable, easy-to-apply tool for which not much equipment, but a good training, of course, is necessary to apply. And there is one particular group of techniques which we summarize as POCUS, point-of-care ultrasound. It has been developed, my own group developed or contributed mostly to furthering this in the diagnosis of tuberculosis in young children, actually. But as you can see, there are many, many applications and many different techniques how to assess, in a case of sepsis with an unknown focus, how to assess a patient rapidly but thoroughly. And of course, and this is actually particularly important where we do not have the possibility to capitalize on the services of radiologists. And in many countries, also in affluent settings, ultrasound is not a domain of radiologists only, but clinicians involved in patient care, internists, other specialties have learned to apply these techniques. Now, in a personnel-rich environment with a critical mass of caregivers, actually, in-house training might not be that difficult, but most settings, many settings, here just some examples of how we can use POCUS in shock, actually, and I refer to the original publications. But in some places, it might be very, very important to use techniques like this one, which we called remote FASH. This is an acronym which refers to the fast assessment of HIV positive patients with a suspicion of tuberculosis. But the point we want to make here is that it is well possible in most settings to set up training schemes where people who are working on the ground might be trained with a relative limited input in terms of time by somebody who is watching remotely, actually. And there are techniques like this. We have shown, for example, in a small cohort of patients in Lambaréné, Gabon, where such a remotely controlled, remotely guided ultrasound assessment might lead to therapeutic consequences, actually. And I would like to encourage you to refer to some papers pertaining to helping people in resource-poor settings to apply these simple ultrasound techniques, maybe with the help and expertise of an external advisor. These techniques really make a difference. And ultrasound, I think, is emerging or has already emerged as one of the most inexpensive, certainly non-invasive and increasingly also cheap techniques, which require a fairly intense training. But once that's done and once these training schemes are maintained, this is one of our formidable tools to assess patients at risk or already having sepsis, actually. And again, I would like to summarize. Of course, we do have a very, very sophisticated tools to diagnose sepsis these days. There are panels and arrays of biomarkers, more or less reliable. The possibility to escalate treatment on an intensive care unit. Even if we lack many of those resources in most settings, those basic tools which I have mentioned here and a high level of alertness, a high level of applying very, very basic clinical skills can make all the difference with our patients, no matter in which setting we operate. And with this, I'm already coming to an end. This format doesn't allow for queries and answers, but I would like to thank you for your interest, and I hope that this short consideration of identifying the source of sepsis is helpful in your daily work. Thank you very much indeed, and goodbye.